Hello, everybody. John Marshall, joined today by Dr. Ben Weinberg and Dr. Ronit Yarden. Dr. Yarden's from the Colorectal Cancer Alliance. Ben's my partner at Georgetown Lombardi the Rush Center for the Cure of GI Cancers. We were lucky enough to just get a sort of overview of how to manage colorectal cancer published very quickly, within a week and a half from submission, so that folks out there could have some general guidelines as to how to manage colorectal cancer during the COVID pandemic. And so it was really Ronit's idea, frankly. She had found something on Twitter, I think it was, of a table that really looked at, you know, putting together guidelines as to what should we do no matter what could we postpone, what could we modify safely. And so we just started to throw back and forth those ideas, and in the end we had a paper that was worthy of publishing. So again, Ronit, thank you so much for being the inspiration and the spark for this on behalf of the Colorectal Cancer Alliance. But, you know, Ben, let's talk a little bit about, you know, things that we, you know, as you say, cancer is not elective. And so there are certain things, certain moments in a patient's treatment that we need to do no matter what. It's worth the risk. And maybe run down some of those things with us that you think are so important that we should start even in the face of the COVID pandemic.
Yeah, so I think those are really good points. So again, we don't want to be compromising a long-term benefit at the, you know, because of short-term risk. So things like adjuvant therapy, where we know based on long-term survival data actually result in curing more patients with stage 3 colorectal cancer, that's not something we can really give up on, because we know that even though we'd be reducing the short-term risk, we'd be compromising long-term benefit. So in patients who could directly benefit from adjuvant chemotherapy, those are things we would still recommend proceeding. The question is sort of, you know, what regimen, the dose intensity, and the timing. So we typically want to start adjuvant therapy within 4 to 12 weeks post-operatively. We think the sooner the better generally, but there are certain things like maybe if you're going to use oxaliplatin, to maybe add that in a little later, depending on when you think the peak of your COVID pandemic is going to come, although that's been sort of a moving target in, I know, in the Washington, D.C. area. To do neoadjuvant therapy for rectal cancer, if appropriate, that should still be considered, although maybe using more short course radiation as opposed to traditional long course chemo radiation. And then in the metastatic setting, really trying to space out therapies, minimize toxicity if we know we're not curing patients, but you know, these patients also need palliation to not compromise that benefit as well.
You know, I was thinking in frontline, Ronit, I'd appreciate your thoughts on this too, is that, you know, unlike me, I've actually changed some of my perspective about being more intense initially with some of the, you know, triplet and quadruple therapy for frontline metastatic colon cancer, the survival benefit downstream from that. So, you know, but that's sort of counter to one of our principles of being kinder and gentler to avoid toxicity. And so, you know, my thought was, yeah, go ahead and do a triplet regimen initially, particularly in patients with larger, bulkier tumors, for a couple of 3 cycles maybe, and then back off. So, you know, balancing that, because as you say, Ben, it's going to be long-term follow-up and long-term survival. Ronit, what's sort of the feedback you're getting from patients on the front lines about these kinds of modifications?
So I think when I reached out to you, there were no guidelines, and patients were calling our helpline constantly and frantically about what to do, what's the right thing to do, what's the course of treatment that they should get, and what is right and what is wrong if their center is closed and they postpone their appointments, or they are. So that is when I reached, and I thought we saw a need to provide some information that is evidence-based and for the patients. So I think this is a new, I think a lot of institutions had maybe their own guidelines, but I think this will be great to share with our patients and show them that there is some path that their physicians can follow, and that they will feel comfortable with that.
And it's really this first column that we created of you really should start, because, the risk, while it's small, is real of getting an infection, but the benefit of these treatments would be major. So you have to go forward. One that I struggled with early on was a patient of ours who needed a palliative procedure. And people were saying, oh, well, we can push that off. And we're talking about a couple of months here. So if someone's suffering from pain or complications of cancer, even if it's in a non-curable setting, I was a strong advocate for pushing for palliative treatment, whether that's radiation or an IR procedure or something like that. Ben, your take on that?
Yeah, I agree completely. I had patients who were teed up for large HIPEC cytoreductive surgeries, and I know the patient was very concerned. We've done all this chemotherapy and had planned, for timing of a HIPEC, and now would that be compromised? Well, it turns out it's not counted as an elective surgery, and it's going to proceed as scheduled. But that is a resource allocation issue, because those surgeries are not small outpatient procedures. Those are in the hospital, ICU, weeks sometimes. And that's using a lot of resources that if you have a COVID pandemic and simultaneously, that's a real strain. So I know there are competing things from more of a population, institutional level, system level. But for the individual patients, if they are really on track for some sort of therapy like that, I think we need to stay on track.
Yeah, I mean, we were just yesterday on our tumor board discussing a case of, primary resection of a pancreas cancer. And it happens right now. We had a little window at our hospital where we would have an ICU bed. And we're not sure what next week or the week after holds, but right now we do. So it's one of those things, as you say, it's a multidisciplinary resource, that judgment that needs to be made for our individual patients. Let's kind of go to the other end of the spectrum. If those are things that we've got to do right now, what are the things that we can kick down the road a little bit or drag our feet, and maybe make a lower risk for the individual patient?
So I think you alluded to this, maybe starting maintenance therapy earlier for patients with metastatic colon cancer, especially if they're symptomatic, maybe starting off more intense, but then quickly backing off. There's no magic behind giving 6 months, 8 cycles, whatever. After 2 to 4 cycles, sometimes you're seeing a response, patients feeling better. There's, a lot of data to support you could probably dose escalate without compromising significant efficacy.
Yeah, so these are patients maybe who got started in February, January, who are now coming up on, 3, 4 months of treatment, backing off on them for sure, right?
Right. And we're firm believers in maintenance therapy, but, a lot of others do treatment holidays, things like that. Yeah. I think definitely spacing out chemotherapy, making Q2 week regimens, Q3 week. If someone's on a biologic only, like an EGFR therapy, maybe dropping the chemo and continuing the EGFR therapy and even spacing that out given its long half-life. Again, we do have some randomized trials showing that continuing chemo, for instance, with EGFR therapy is preferred over monotherapy. But again, the differences are not huge. And those are things to think about in the pandemic setting where, you're palliating and you don't want to increase toxicity.
Yeah. Ronit, I mean, one of my patients emailed me a couple of weeks ago that basically said it's time for their annual CT scan. And they felt fine, but they're, with all patients, you get ramped up and nervous as that scan's timing is coming up. And we were talking back and forth about, should you push it off another couple of months versus, going into some, outside CT place and getting it done. I'm sure the same has been true for your patients. I advise the patient to take, to push it off a little bit if she could. What's your thought on that? What are you hearing?
Yeah, I think a lot of patients are very concerned about being immunocompromised. And this obviously it's important for a patient on treatment, but I think a lot of our survivors also worried about their immune system and if they're more sensitive to, to the COVID-19 being out there. So I think postponing is something that, on the other hand, they're worried about postponing and then not detecting early enough if there's any changes in their
yeah.
tumors.
Yeah.
Yeah, I would say I get that question actually a lot from patients, patient survivors who completed their adjuvant therapy 3-6 months ago. And they're like, well, I don't have active cancer. I just had my CAT scan. I'm not on chemotherapy. So what is my risk relative to someone who doesn't have cancer? Because I know having cancer in the COVID setting is bad. And I tell them that their risk is really very similar to that of someone who does not have cancer, but I cannot say it is necessarily equivalent.
Yeah.
On the flip side, the recommendation is the same. You have to stay home, stay away from other people, minimize trips outside the house. So while the recommendations are the same, it's not a comforting answer, not something we really know the true answer to.
Yeah. One last one just to cover from the paper was the rectal cancer cases where I've been really uncomfortable watching and waiting patients who have a nice neoadjuvant or very good neoadjuvant response. But with all of this going on, if a patient of mine had a good response to chemo radiation that's been given over the last few months, I might say it's okay to push off that surgery. What's your thoughts on that, Ben?
Yeah, so I'm inclined to agree. I'm not a watch and waiter. I guess the exceptions to that are especially low rectal cancers that would require permanent ostomy. Those are the people who probably should be, given the chance to watch it. I think the question is sort of how you watch and wait. So you're going to have to watch very closely.
Yeah, yeah. And that still means coming in for scopes and things like that. So the trade-off there is
trade-off.
Not perfect. All right. Well, thank you guys very much for not only helping with the paper and being co-authors and everything else, but also joining me to kind of discuss for everyone else what's going on out there. We'll refer people to our paper to read it and complete. It's not very long, so it's a short attention span kind of paper, and hopefully it'll help as you manage your patients. Remember, it's still a individual decision. These are some basic guidelines or rules that we would sort of suggest following. But every patient is an individual case and needs to be modified. Decision-making needs to be modified accordingly. So thanks everybody for joining us.